Well, it's a great pleasure to welcome you to our first keynote address of the conference. And Stephen Laureys is a neurologist and heads the Coma Science Group at Liège in Belgium. We've tried in the past to get Stephen to come and speak to us. He's well known for his landmark studies on detecting or searching for consciousness in comatose patients. He's published widely in this area, found some very startling and amazing results. And this is a very important clinical area, and with ethical and moral implications, as well as scientific and philosophical. So without further ado, please welcome Dr. Stephen Laureys. Is this yours? Yeah.
Thank you very much for this kind invitation, and congratulations for putting up such an exciting meeting where the different disciplines meet. And we just heard today and the previous days how challenging it is to even define what we're studying, to try and better understand consciousness. And I'll, in the next 80 minutes, use a more clinical approach and reduce the complexity of what we call consciousness to two main components. First of all, you need to be awake in order to be aware of your environment and aware of yourself. And this is kind of what we experience every night when we go to sleep. Your level of wakefulness goes down up to the point you lose awareness of what's happening around you. Of course, in REM sleep, something paradoxical occurs, that is the presence of subjectivity, of dreaming, in what seems to be from the outside a unconscious sleeping subject in paradoxical sleep. And then there's, of course, the very interesting, and I think at present still not enough studied, notion of lucid dreaming. Now, patients in coma are unconscious because by definition they cannot be awakened. So clinically a patient in coma will never open the eyes even when we stimulate her or him. So clinically this is how we quantify wakefulness. This is quite straightforward. We just look for eye opening. So you're all sitting here, eyes wide open, so chances are you're aware of what's being said. And the same holds for pharmacological coma or general anesthesia, where again we have different drugs where we can decrease the level of wakefulness so that patients lose the awareness of their environment. Now, coma will not last for more than a couple of days or weeks, and some of these will show a dissociation, meaning they will awaken from their coma, they will open their eyes, they will move, but all the movements will be considered as reflex. And this was coined in the 70s as the persistent vegetative state. I prefer to say unresponsive wakefulness, because this is how clinically we quantify awareness. So our awareness test basically comes down to checking if there is a response to command. So if we would ask the question, is Stuart here conscious, we would ask him to do something. So squeeze my hand or lift your left arm, okay? So I hope even for the philosophers here, this would be proof that Stuart is aware of his environment. And I think it's very interesting. Of course, there's, as said, the whole clinical problem of dealing with these patients who are vegetative unresponsive. But also they permit to better understand what's what we call the neural correlate of awareness, these dissociated states where you are awake yet unaware. And there's some other examples in neurology, as we will see in epilepsy and in sleepwalking, where again you can have reflex motor behavior without passing the awareness test, without showing response to commands. Now in 2002, we had the definition of yet another clinical entity called minimally responsive or minimally conscious patients. And this was recently subcategorized in what we called minimally conscious minus, where there is non-reflex behavior, and minimally conscious state plus, where there is command following. So non-reflex movements are, for example, a patient who, after the period of coma, awakens, shows only reflex movements, and then at a given time, classically a couple of weeks or months later, would show, for example, smiling to the presence of the mother in the room, and only if it's the mother. We don't regard that as a reflex. Or eye tracking. They would follow with the eyes if you would go in the room from left to right, or they would orient to painful stimulation. These are considered MCS minus, and then as soon as you have a response to your command, they're called MCS plus, but by definition, you cannot communicate with these patients who are minimally conscious or minimally responsive. And it's very important to identify the last entity, which is pseudo coma or locked-in syndrome, where patients after their coma awaken fully conscious, yet unable to show that they're conscious, unable to move their limbs, unable to speak or to have any voluntary control of facial muscles. And classically, this is caused by a lesion in the brainstem, in the ventral pontine area, that basically cuts through all the motor fibers and touches the cranial nerve nuclei responsible for speaking. But you have an intact brain, just disconnected from the muscle control. So when we reduce consciousness to these two dimensions, wakefulness and awareness, and we have just said that there is a positive correlation between them, one can then again reduce awareness to its two main components. And that is awareness of the environment, what we call external awareness, everything coming through your senses, what you hear, what you feel, what you see, and internal awareness, or basically all these stimulus-independent thoughts, mind-wandering, mental imagery, or if you wish, awareness of self, but it's already a more tricky term. And there, the correlation is different. And it seems to be the case that at any given moment in time, it's either one or more one than the other. And I think now the challenge really is to find the neural correlates of these two types of awareness. And during this talk, I'm trying to show evidence that we now do know that consciousness is not an emergent property of global overall brain function, but that there are critical networks. And you see them here. It's a widespread frontoparietal global neuronal workspace, where, as we'll see, for you to be consciously aware of your environment, of external awareness, you need these areas in red. Lateral frontoparietal associative cortical network of both hemispheres. Whereas awareness, internal awareness, stimulus-independent thoughts are critically dependent on this midline core shown in blue. And what is important is how these areas interact, that is the functional connectivity, cortical-cortical, and as we'll see, thalamocortical, which are critical for the emergence of awareness. So let us start by the first question, which is, would there be a relationship between consciousness and overall brain function as we can measure it through positron emission tomography and metabolic glucose PET scan studies? So you should all be up here. Your gray matter activity, these 100 billions of neurons are using a lot of energy. They're the cells that use the most energy, and we can measure that. And you see here the colors, red and yellow, of that gray matter that are highly active, 100% of activity when you're consciously aware. And let us start with the extreme, which is brain death. You see here, this is the so-called empty skull sign. There is only activity here to be seen in the skin surrounding your skull and none in any of these billions of neurons. When you go to sleep, in deep sleep, slow wave sleep, as you can see, overall brain activity decreases to up to 60% of normal waking values. And then in paradoxical sleep, something paradoxical happens. You have near normal overall brain metabolism. Also in general anesthesia, with basically any drug that is used in the operating room, with some exceptions, you will have a massive global decrease of around 50% below normal waking values. And of course, when you stop the drug, consciousness returns, and so does overall brain metabolism. Now, that relationship between global brain metabolism or function and consciousness is not that straightforward in pathological conditions such as coma or the vegetative state, where, as you can see, there is this massive dramatic reduction, about 40% of normal values, yet those patients who recover, as you can see, do not recover near normal overall metabolic activity. In other words, for you to be consciously aware, you don't need your whole brain function. There are some areas in your brain that are more critical than others for you to be aware of your environment and of self. And now, using new statistical methods, voxel-based, we can identify which truly is this awareness network, if you wish, if we may oversimplify it like that. So these are the patients we're talking about. This is a video I received from the mother of Terry Schiavo, a much mediatized patient that I think illustrates well how difficult it can be to say something meaningful about these patients' level and content of consciousness. So you see her eyes wide open and moving, but all the movements are considered reflexes. So what we can now do for the past 15 years or so is more than just looking at movement and motor responsiveness and trying to quantify these patients' awareness. We can actually go and measure their residual brain function. And when we look for the areas which are systematically dysfunctional in this condition of wakefulness without awareness, you see that one identifies a network. It's widespread. It's frontoparietal, global neuronal workspace of both hemispheres, dorsolateral, prefrontal, temporoparietal of both the left and the right hemisphere. And as you can see here, the impairment in this midline core, where you see the mesiofrontal, anterior cingulate cortex, and here in the back, this triangle of precuneus and posterior cingulate cortex, which systematically are hypometabolic, severely hypometabolic in these patients that are awake yet unaware. And of course, what is spared is this network important for wakefulness, for survival, for all the autonomic functions in the brainstem at the subcortical level. And not only are these areas systematically impaired when patients are unaware, as we've shown in this early study from the 90s, they also recover near normal metabolic activity when patients recover awareness. So we're closer to some causal link here. You see in yellow the areas which were impaired when patients were unaware and recovered near normal metabolism when awareness returns. And as said, we have in neurology some other examples of what we could call transient vegetative or unresponsive states. One example are absence seizures. You don't have the sound, but you don't need it. You see this girl talking, and she will be really absent for a couple of seconds. You see it here, and then she would just resume the interaction. Here it is with the environment. Now, again, thanks to functional neuroimaging, we can know what's happening during this absence seizure. And you see here results of an FMRI study by Helmut Laufs. In red, you see the areas that decrease their bold activity as we measure with fMRI, and you'll recognize this widespread frontoparietal network of both hemispheres and of this midline core. And the same for another type of epilepsy. These are complex partial seizures, where when you compare those seizures where there's no loss of awareness with those where there is loss of awareness, what seems to be different here in this study by Hal Blumenfeld is in green, again, this frontoparietal network that decreases its activity, as here shown by SPECT imaging. And finally, in sleepwalking, here you see a study by Claudio Bassetti in Switzerland. He had this Lancet paper because he was the first and so far only to be able, again, to inject a SPECT tracer right at this moment when the patient's awake from slow wave sleep, shows this motor activity, and again, you see it's more noisy, of course, because it's N is 1 study in yellow, a decrease in this widespread frontoparietal network. So we've reason to believe that for you to be consciously aware of your environment and self, you need this functional integrity in this widespread frontoparietal global network, not only in vegetative or unresponsive state patients, as you can see here on the top, in black frontal parietal precuneus mesiofrontal, but also, as you see, in coma, in slow wave sleep, and in general anesthesia, in this case, in propofol anesthesia. And within this network, there is what I would call a critical hub, which is a very intriguing area, this triangle here, which is the most metabolically active in your gray matter when you're awake and aware. And it's exactly this area which is the most impaired when you're unaware in here coma or vegetative state, and of course is fully preserved when you're in a pseudo coma or in a locked-in syndrome. And it is minimally active when you're minimally conscious. And this was confirmed recently by the group of Nico Schiff in New York, who were able to study a so-called miracle case of recovery in a person called Terry Wallace. He had a road accident here in the States, and he was considered, they reported him as comatose. In reality, we don't see miracle recoveries from coma many years after. As said, coma as itself only lasts for a couple of days or weeks. He was considered to be in a vegetative state, but it was one of these examples where the diagnosis was wrong. When Nico Schiff went to see his medical files, it was clear that he was minimally conscious already some months after his brain trauma. But interestingly here is that he started to talk, and he started to talk 19 years after his traumatic brain injury. His first words were mom, second word was Pepsi, an American patient, and interestingly, the group in New York was able to use MRI and what we call diffusion-weighted imaging to study what they considered axonal regrowth, you see here, identified by these yellow lines in this triangle here, midline posterior area of the brain, precuneus posterior cingulate, that occurred during this recovery from a very long period of unresponsiveness. So basically this patient is rejecting the old dogma that neural plasticity only occurs in the acute setting. As I've learned in medical school, that plasticity is limited to the first months, the first 12 months maximum. Well, he shows us that even decades after, there are some plastic changes in the brain, even if it's very rare. And now the challenge is to better understand this. We also see that this activity in the precuneus and posterior cingulate cortex drops significantly in sleep. You see here the activity, which is very high in wakefulness, is set. It decreases in light sleep, and then you see this drop in slow wave sleep. And similarly in anesthesia, when you compare wakefulness to when patients get drowsy or lightly sedated with in this case again propofol, and when they lose awareness, meaning they no longer respond to our commands, they're unresponsive, you see this massive decrease, which of course is fully reversible when you stop the drug. And together with Brent Vogt in New York, we were able to look also at histological structural connectivity of this, I think, very fascinating critical hub within this frontoparietal awareness network. So what I'm trying to tell you is that you have really this widespread frontoparietal network that is critical for you to be aware, and that you have these lateral areas important for external or sensory or perceptual awareness, and these midline core important for internal awareness. And we recently tested that hypothesis. This is a study done by Audrey van Oudenhuizen and Athena de Merzi, where healthy volunteers were put in an FMRI. There was no particular task. It was a so-called resting state FMRI, except that once in a while they heard a beep and they were asked to tell us what they were experiencing previous to the beep, okay? And the hypothesis was that if they would have high external awareness scores, as here, they would have a higher activity in these lateral frontoparietal areas, whereas if they were more self-oriented, having high scores of internal awareness, you see this correlated, as predicted, with a higher fMRI activity in this midline core. They also could look at the temporal dynamics, and it turns out, as said, that you have these two systems that spontaneously will oscillate, and we know from fMRI studies in resting state that they oscillate with about a 0.05 hertz frequency, which is a switch about every 20 seconds, and that is exactly what they also observed behaviorally. You see here on this graph time, in the abscess and in the ordinate, you see the awareness scores from absent to totally externally oriented, like here. And then you see that at those moments, the subjects told us they were very little internally aware. So they anti-correlated one with another, and they tend to switch when we do a spectral analysis at a frequency of around 0.05 hertz. I think there is now increasing evidence in favor of this hypothesis. This is a study by Melanie Bully, published a couple of years ago in PNAS, where she used a laser stimulus on the healthy volunteer's hand, so looking at the correlates of external or sensory awareness, and she made it such that the intensity of the laser was at a threshold where half of the time subjects told us, yes, I felt it, and the other half, they didn't feel anything. And if you subtract those two fMRI data sets, what do you identify? Not primary somatosensory cortex, but this frontoparietal network on both hemispheres for matched laser stimuli. What makes you perceive or not perceive seems to be the activity, the functional integration within this frontoparietal, this lateral frontoparietal network. It is more difficult for us to study internal, or if you wish, self-awareness. And we've been using a lot the patient's own name, which, as we know in daily life from what is called the cocktail party effect, when you hear your own name, Stuart, it will grab your attention. And we're making good use of that in these patients with disorders of consciousness. This is a study by the group in China, where you see that the activity of this midline core here, the anterior cingulate, is higher in patients who are more conscious, as quantified here by a clinical scale called the Coma Recovery Scale. We also looked at how these two networks would dissociate in hypnosis. We have quite a tradition in Liège with works by Marie-Lise Femonville and Athena de Merzi looking at hypnotic state, and the prediction was that there you have a state of dissociation, as you can see here, where you're more dissociated as compared to the distraction control task or to normal wakefulness, and as said, you have less external thoughts. This is actually being used in the operating room by Marie-Lise Femonville, and she's published extensively on that, where surgeries where classically you would need general anesthesia here now are done in patients who are conscious, yet in this hypnotic state. And not only she has published this in peer-reviewed papers, but now also the surgeons actually ask for this hypnotic state intervention, so really it must be true. And you see with fMRI that, as predicted, this lateral frontoparietal network breaks down, is no longer identified in this condition. So again, going with the hypothesis. So the point I'm trying to make is that for conscious awareness, you really need this integration in this frontoparietal network. And consciousness is, for me, not emerging at the lower primary cortical network level. And again, an older study we did in patients who were vegetative, unresponsive, where using auditory stimuli, we still observed cortical activation. You see here in red on this coronal slice, but it is limited to these lower level, what I prefer to call slave systems, and it is only in conscious or minimally conscious state patients that the activity is more, not only more intense, but more widespread, and most importantly, is leading to this integrated activity with a functional connectivity between these sensory areas you see here in green and the functional connections with the higher level frontoparietal network, lateral frontoparietal network, we consider critical for external awareness. So patients who are vegetative, comatose, unresponsive will maybe activate low-level cortical areas, but this will be like an island disconnected from these higher order frontoparietal networks. And now using novel methodological tools, we can actually go further and not only study functional connectivity, but also the directionality of these connections. And this is a recent study by Melanie, where together with the London group led by Carl Friston, she was able to show that using high-density EEG and an auditory oddball paradigm, where patients hear just beeps, and you can identify different areas here, area 1, which is primary auditory cortex, and area 2, higher order auditory area, and then 3, this frontoparietal, this associative frontoparietal network, where it turns out that for you to be conscious, even minimally conscious, you need this top-down feedback connection illustrated here by this red arrow, which was never observed in patients who were unconscious vegetative. So for you to be consciously aware, we think you need this integration in a frontoparietal network. Cortical-cortical connectivity, as said, seems to be critical, but also thalamocortical connectivity, as shown here in, again, an early study where we were able to show in patients that were vegetative, unresponsive, that there is a breakdown of the connections illustrated by these red arrows between these midline and lateral associative frontoparietal networks and the thalamus, more precisely the non-specific central intralaminar thalamic nuclei, and we could show that those patients that recover awareness show recovery of this thalamocortical connectivity, pointing to the critical role of these thalamocortical loops for the emergence of conscious awareness. And this actually led to the development of a therapeutic tool by the group of Nico Schiff in New York, who went and put in both intralaminar thalamic nuclei, as you can see here, a electrode, and applied deep brain stimulation to the thalamus in a post-traumatic minimally conscious state patient, and could improve this patient's consciousness. So illustrating how, of course, a better understanding of the phenomenon leads to possible therapeutic options, bringing us to the next part of the talk after discussing what we consider the scientific interest, the search for the neural correlates, which is the clinical interest. And I think we really face a major challenge there, where as physicians, as neurologists, dealing with these patients, we try to say something meaningful about the patient's consciousness or cognitive capacity, while all we actually do at the bedside is looking at patients' motor responsiveness. So as said, as soon as the patient in coma awakes his arousal system, meaning he will open the eyes and only show reflex movements, patients are called vegetative or unresponsive. And the big question for us is the patient conscious? That means the search for non-reflex movements or response to commands. If the patient is unconscious, the question is, will he have a chance to one day recover consciousness? If we consider there are signs of consciousness, the question is, what is that consciousness like? And that needs communication, which is the next big boundary, actually the boundary defining recovery from minimally responsive or minimally conscious states. And this is very, very challenging. Actually, we've seen a number of cases where the label vegetative was wrong, and sometimes it can be wrong for many, many years, as was the case in this patient here that also made the international media and actually led us to do a scientific study on how frequent that problem is. And Caroline Schneckers in our group looked at more than 100 coma survivors, asked the clinical team about their consensus diagnosis, and they had the option considering the patient vegetative, unresponsive, or minimally conscious, or I don't know. Turns out that 45 patients in this multicentric study funded by the Ministry of Health in Belgium had the diagnosis, clinical consensus, vegetative, unconscious. In reality, it turns out that 40% of these patients had some signs of consciousness. Of course, this is unacceptable, such a high rate of diagnostic error. And in that paper, she also proposed a solution to that system, which is a standardized way to look for these small signs of consciousness. And there I think that at present, the best scale we have is the coma recovery scale. And for those interested, for those with a clinical practice, we actually have developed a video explaining how you should use this scale, and we can send it to you if it can be of any use. So there really is a problem when we're dealing with these coma survivors and we're trying to quantify their consciousness. We need to be very, very careful, and there's a number of reasons why sometimes we get it wrong. One of the most frequent clinical signs we see when patients emerge from this condition of persistent vegetative state, or I prefer unresponsive wakefulness, is that they will start tracking with the eyes for moving objects. And again, I think it's important that clinically we decide how we're going to look and quantify these clinical signs, in this case, eye tracking. So again, in medical school, I learned, like I think all physicians here, to just move an object and check if the patient would track it. And this study, Audrey van Oudenhuizen, shows that maybe we should be using a mirror. As you see here in white, there is a significant proportion of patients that will track a mirror, but not a moving person or a moving object, so possibly leading to a misdiagnosis. And just as for the own name that has this capacity of grabbing our attention, seeing your own face, this autoreferential, emotionally salient stimulus, again, I think should be used more in clinical practice. So for all these reasons, I think we should be very careful when we consider patients vegetative, and I don't like the name persistent vegetative state, and when you hit Google, you will find many references to these patients being compared to vegetables, and it has this intrinsic negative connotations for the past 30 years, so we proposed an alternative neutral name, which is just calling these patients what we see at the bedside, that is, they're wakeful, yet they're unresponsive. They don't respond to simple commands. And again, this also is the result of a number of studies that have shown that we really need to be careful, and that all we do at the bedside is looking at motor responsiveness. And there have been now a number of cases identified where patients from the outside looked unconscious, yet when we go and do more than just look at motor responsiveness, that is, looking at their brain responsiveness directly with these new technological tools we have, we can sometimes be surprised. And on this slide, you see the result of a study that came out last year, where together with the group in Cambridge, we recruited a number of patients that survived their coma, showed no sign of consciousness, yet when we put them in an FMRI scanner and we asked them questions, they actually activated their brain in areas identical to those in controls. The questions we asked were a bit strange. We asked these patients to imagine playing tennis. Now, why did we do that? That is because you cannot imagine to play sports or tennis if you really do this kind of mental imagery. You will activate your supplementary motor area. And we can easily pick it up with fMRI. And we had another task where we see here in blue another set of areas light up. And in this task, they were asked to imagine walking around, finding their way in their home. And you see this area far away from the supplementary motor area, which is the parahippocampal gyrus. So with this tool, we went to see these patients and actually could show that there are patients with, as you can see, very severely brain damage, hydrocephalus, very limited actual cortical areas that are preserved, and yet when we asked them to do the motor imagery task, they activated, as did healthy controls. And we could, in this paper, even push it further and make this into a communication tool. So we could ask these patients questions, and in the first patient where we were able to do this, we asked 6 subsequent questions, and the first 5 were answered correctly. And these were easy questions like, is your father's name Stuart, or is your father's name John? And at the end of the day, Audrey van Oudenhuizen and Martin Manti came back and gave all the correct answers, just looking at FMRI data and being unable to have any communication at the bedside. Of course, if you really want to make a difference here in terms of their quality of life and their real-life interaction, FMRI is not going to do it, because as soon as the patient comes out of the scanner, everything's gone. So we need cheaper and portable alternatives, and this is a recent paper, again together with the Cambridge group, where we basically did the same thing, now with EEG, event-related potential study, and we asked patients to move, but we didn't look at the movement as such. We looked at brain activity. And when you imagine to move your foot, you will have this area in your motor cortex activating, which is different from imagining moving your hand. You know, the Penfield pedunculus, then the activation is more lateral. And again, we could show that in patients that were clinically vegetative, in this case, 3 of the patients could do the task. We also could use it in patients who are minimally conscious state minus. Remember, they don't show response to command, but again, here using EEG, we could show that some of them did show EEG signs of awareness unavailable at the bedside. So these so-called brain-computer interfaces, I think, really are making a difference, and this is actually moving from the bench to the bedside. And we had a patient I saw now more than 5 years ago, where in our intensive care unit at the Liège University Hospital, she was being cared for. She was a young woman with a brainstem stroke, and she didn't show any clinical sign of consciousness. Even if you would open the eyes manually and look and ask for looking down or up, nothing happened. So we decided to do this brain-computer interface where, again, using EEG, we presented a number of stimuli. In this case, it was a number of words, of names, and then we asked her to count the number of times she heard this or that target name. And only then we saw this change in the electrical activity of the brain, this so-called P3 response in this active paradigm. And this was the only proof we had that she was actually conscious. This was a case of total locked-in syndrome, which is very rare, where even the eye movement cannot be controlled, yet the patient was aware. And we continued the intensive care, and she, weeks later, only recovered some movement in finger and now can control her wheelchair. And of course, we can now do much more complicated analysis. This is a study that came out by the group in Austria, where they looked at theta synchronization during such active ERP paradigms. And again, here showed in MCS minus that despite the fact that clinically you have no response, well, if you look at brain activity directly, you might get a response. Now, of course, all of this can be biased in patients who don't understand the command. So the problem of aphasia in the assessment of consciousness in brain damaged patients is really a challenge. And we actually looked at that together with Steve Mejerus in our lab, who's a language expert. And it turns out that basically all the patients with a severe brain damage we see have impairment in the language network to some or the other extent. And that if you look at the difference between MCS minus and MCS plus, so the absence or presence of command following, what seems to make the difference is this activity in the left hemisphere, in the dominant hemisphere, encompassing the language network. So truly this is a problem for us when we're confronted with patients who basically have a left-sided hemispherectomy. What is it like to have your left hemisphere taken away, basically after trauma or a severe stroke? We know that these patients will fail the awareness test. They don't understand the commands, yet we also know that with your right hemisphere you can still perceive emotion, you can still perceive pain, and it's really very difficult for us to say meaningful things about their level of consciousness. So what we need is basically language-independent tools, and this is a recent study by Christophe Phillips, our engineer in Liège, who published what he called an automated consciousness classifier. And he's been using a relevance vector machine, which basically will, in this case, make use of the metabolic PET data, feed them to the computer, and in hundreds, thousands of dimensions, will try to classify what is conscious, what is an unconscious patient. And he showed actually that the machine could do it with 100% accuracy, and it outperformed the human eye. And it was then confirmed and tested with pseudo coma or locked-in syndrome patients. And the most informative areas in the brain for this classifier were in the brainstem. We know this was to be predicted. These areas are preserved in patients who recover wakefulness. But here, these awareness-related midline structures we've already talked about, precuneus, posterior cingulate cortex, were with mesiofrontal areas, as you can see, the most informative for this user-independent classifier that really gives you, at the end of the day, a probability of being conscious or not. So you end up with this analysis of fluorodeoxyglucose, of metabolic positron emission tomography data, where classically what you see in patients who are vegetative, unresponsive, is this widespread frontoparietal impairment you see here in blue of both hemispheres and of the midline structure we think is important for self-awareness. In minimally conscious state patients, it turns out that what is the most common is a recovery of these lateral areas, so they recover mainly some sense of awareness of the environment, but have some evidence of impaired internal awareness even when they emerge from the condition. And of course, in patients who are locked in or in pseudo coma, there isn't any cortical area that is dysfunctional, only brainstem and cerebellum. We also showed that the coma recovery scale, so remember this is the clinical scale we use, that the score there correlates with the activity in this widespread frontoparietal network. We can also use this tool, use functional neuroimaging, to better understand some ambiguous signs. One of them is visual fixation. So we just said that visual tracking is very important and informative as a sign, a first sign of consciousness. There is a lot of debate whether or not you can have visual fixation without awareness. And so in the guidelines, the medical guidelines, you will see that for some countries this is accepted, even in patients who are considered vegetative. For others, it's a sign already for emergence. But this is like expert opinion, it's not evidence-based. So we decided to, with Marie-Aurélie Bruno, to use positron emission tomography again, and you can see that patients who are without fixation, considered in a vegetative state, as compared to those with fixation but were matched for all possible confounds, showed again a massive impairment in metabolism in this frontoparietal network. You see in blue, they both have this dysfunction in the awareness network, where only here in orange and yellow, it's the brainstem that has some residual activity. In other words, visual fixation, according to this study, would not be a sign of consciousness, can be considered a reflex. So as said, I think we need more markers of awareness, and we need markers that do not need understanding of language or do not require the active collaboration of the patient. And we also, with the group in Milano, you see here on the picture Marcello Massimini, who's a pioneer in a new technique called EEG-TMS. It is combining transcranial magnetic stimulation with high-density EEG. So you would be able to excite, to hit one part of the cortex, and with simultaneous EEG measurements, look if there is or is not residual functional connectivity. And so in this paper that just came out in Brain, we were able to show that in patients who are vegetative, when you hit the cortex, illustrated here with this white cross, when they're unconscious, you would see a stereotyped reflex, stereotyped response under the coil, but it would not have this connectivity, this cortical spread that we only saw when patients recovered consciousness or some minimal form of consciousness, and patients that stayed vegetative, as you can see here, remained with a disconnected, stereotyped response using EEG-TMS. And I think this is a very useful tool that we'll see more in the field of neurology. Again, pointing to the critical role of functional connectivity for the emergence of consciousness. Now, we can, as said, also look at resting state brain function using fMRI. And since the work of Mark Rakel, who's been the pioneer in this field, we know that we can, by just putting somebody in the fMRI, there's no task, but there is still, as you know, thinking going on. We can identify networks in this so-called default or resting state. And again, there's been a lot of debate whether these networks truly reflect some conscious thoughts or whether they would be the result of some artifact coming from the machine or coming from heart rate or respiration. So how it works is, as you see here, you put the subject in the machine, you just hit the record button, and you can visualize these networks that would show coherent connected neural activity. So you have time here again in the abscess and in the ordinate. You see in red this mesiofrontal anterior cingulate region that shows spontaneous fluctuations in activity and is correlated with this area in the back here, precuneus posterior cingulate cortex. So they go up and down together. They're functionally connected. What does it mean? Does it truly mean that there would be some kind of stimulus-independent thoughts? Well, to try and figure it out, Melanie first looked in this paper at brain death patients. And they still have artificial respiration, they still have a heartbeat, yet you see the whole functional connectivity within this default mode, within this midline network breaks apart. Now, doing functional fMRI, resting state measurements, can be very, very tricky. And movement artifacts are a major confound where, together with Andreas Sodou in our lab, we've been looking at, again, automated ways to extract what we consider true neuronal networks we think reflect true cognitive processes going on. And so he looks both at the spatial and temporal dynamics of the signal. You look here at a classical fingerprint of the fMRI ball signal, and then will or will not accept the measured activity in patients as being truly neuronal, as is shown in this recent paper. And of course, if this is true, we here have a useful tool to look at patients who are comatose. Because if this truly reflects conscious thoughts, it is of interest to look at our patients because they're not supposed to have any conscious thoughts. And to again test that hypothesis, we looked at this default connectivity in pharmacological modulation of consciousness, or in this case, propofol anesthesia. So here again, paper that came out 2 years ago, we do see that there is a breakdown in connectivity within this midline frontoparietal network, including the thalamus, when you compare wakefulness with mild sedation up to the point of unresponsiveness, and then of course it recovers when you stop the drug and consciousness returns. And again, it seems to be that consciousness is not an emergent property of the connectivity in the lower level primary cortices, as shown here. In primary visual cortex, we see that connectivity remains. There's no such correlation with the loss of consciousness. And similar for primary auditory cortices, they still remain in the lower level primary cortical areas without correlation to the loss of consciousness. So as said, if this is true, we can use it in patients with disorders of consciousness after coma, and this is what we did, where we compare here healthy controls and locked-in syndrome patients, and you see a breakdown of connectivity when you look at minimally conscious, vegetative, unresponsive, and comatose patients. So the connectivity within this midline core of frontoparietal areas breaks down depending on the level and content of consciousness after severe brain injury. We can also try and look at it using EEG, which is shown here, a study by Olivia Gossery, who tried to reduce, again, this complexity of the EEG signal to one number. She looked here at entropy measurements, and as predicted, when you compare comatose or unresponsive vegetative state patients to patients who are minimally conscious, you see that there is a significant decrease in entropy when you are without conscious awareness. But again, movement is a major confound because the EEG and the way we calculate entropy can be confounded by the high frequency activity coming from the muscle. So basically, you consider activity coming from the muscles as coming from the brain, and so you can have false positives, as you can see here, with high entropy measurements, which are actually untrue related to the muscular activity. When we gave neuromuscular blocking, as you can see, we have the real signal coming from the brain, and the entropy then is very, very low. So moving now from the challenge of making a better diagnosis and how we can actually improve our clinical diagnosis with all these ancillary testing, we move to the problem of predicting the outcome. So again, the presentation of the own name, as said, can be very powerful, and the group of Haibo D in China has been using the patient's own name in these patients considered vegetative, and in those cases where they saw this atypical high-level cortical activation, it turns out that the prognosis was better. So functional activation studies seem to have prognostic value that needs to be confirmed in larger multicentric studies. And again, we looked at the equivalent with EEG or event-related potential studies. So again, you can present the own name and other names, and you will see this P3 making the difference between your own name and an other name. And we were initially very excited that indeed when you have this response, it turns out, as this study shows, that the chances are higher that you will subsequently recover consciousness. But they are not, as such, an indicator of conscious awareness, because we also had patients that, when we did the test, were truly unaware. Finally, a study where we looked at sleep-wake changes in brain function in patients surviving their coma. There's actually very little research being done. So we used high-density EEG, video EEG in patients who were considered vegetative unresponsive, and actually, despite the fact that they opened their eyes during the day and more frequently closed their eyes during the night and seemed to be asleep, their EEG didn't show significant changes, whereas minimally conscious state patients, as you can see here, did show evidence of what we consider of as slow wave sleep. And interestingly, we could also show that these patients showed what we think is rapid eye movement sleep. In other words, despite the fact that these minimally conscious state patients, where we can't communicate with, will never be able to tell us if they would have any dreaming or oniric activity going on, their EEG shows us that there might be going on more than we could expect just based on our bedside examination. Now, moving on to the challenge of treating these patients, I think the major challenge, one of the major challenges, is to quantifying pain. And just as consciousness, pain is very tricky and difficult to quantify. Again, it needs communication. And this study by Athena Demerzi illustrates how difficult it is for physicians to say something meaningful about pain perception in patients who are vegetative. So she asked over 1,000 medical doctors and over 500 nurses whether or not, according to them, patients in a vegetative state can feel pain. And as you see, the results cannot be more ambiguous than that. About half of the medical doctors thought, yes, there can be perception of pain. And interestingly, when we looked at which variable could predict their answer, it was religion that correlated highly with the answer, yes or no, they don't feel pain. And I think this is to be avoided. You don't want to be in a hospital in Rome or somewhere else and to be treated differently, right? So I think it's a very tricky issue because this has direct therapeutic consequences. If you think they feel pain, you should be giving painkillers. And there again, we have a big problem because how much analgesia should we give? Classically, when you go to the doctor, you tell him you have pain. He will give you a painkiller starting with paracetamol and then going up to morphine and drugs that can have major side effects. Here, we cannot communicate. We, again, needed a scale which was here developed by Caroline Schnackers called the nociception coma scale that permits us, again, to standardize the way we apply pain, and we score the response to pain looking at motor, verbal, visual, and facial expression, giving a score from 0 to 12. And what we published here is that when the score is higher than 7, you should give painkillers and get that number below. So this is now out for clinical validation. In the vegetative, unresponsive patients, we saw not only brainstem and thalamus activation, but also here activation of primary somatosensory cortex. But just as for the auditory stimulation, remember, we saw primary cortical activation, that seems to exist like an island disconnected from the rest of the brain, disconnected from this frontoparietal global neuronal workspace we consider critical for conscious awareness. And this was in sharp contrast to what we saw in patients who were minimally conscious. So remember, it's very difficult, sometimes only the blink of an eye that will make the difference between vegetative and minimally conscious, and yet here you see that their brain scans are very different. Here we see activation to pain, which is very similar to what we see in healthy volunteers, to what we see in your and my brain when we experience pain. Not only activation of the thalamus and of primary somatosensory cortex, but also of the insula and the anterior cingulate cortex, regions we consider critical for the emotional, cognitive perception of pain. In other words, in these patients where by definition they're minimally conscious, they cannot tell us they would feel any pain, I think their brain scans tell us there is pain perception and we should treat them accordingly. In terms of curative treatment of these coma survivors, we recently had a New England Journal of Medicine double-blind, placebo-controlled paper that came out by the group of Joe Giazzino in the States showing the effect of amantadine. And again, I think that functional neuroimaging can help the pharmaceutical industry to target possible drugs that will improve outcome. This is an older study again where we show that amantadine is able to increase the metabolic activity in, again, this widespread frontoparietal network. So to conclude, we of course cannot do this kind of research without dealing with all the ethical aspects. And it is very challenging to do these kinds of studies in patients who, by definition, cannot give their consent. And so we basically needed to define a framework to use these novel technologies in these patients with disorders of consciousness, which is what resulted here in this review paper with Joe Fins from Cornell University in New York, basically defining the framework for doing this challenging work. But of course, it also has major end-of-life implications. What would you like to be done if you yourself would end up to be in a permanent vegetative or unresponsive state? So we looked at this in a survey in Europe, looking at more than 2,400 medical doctors, and we asked a number of questions, one of them being, if you yourself would be in a chronic vegetative state, would you like to be kept alive? And you see that there's differences between vegetative and minimally conscious state scenarios, but also, and importantly, between, it depends where you ask the question. Here in Northern Europe, you will have different answers than if you ask the question in Southern Europe. So it's very, very difficult, and we're working currently on European guidelines, but we will need to take into account these major cultural differences that exist both within Europe as within the States. And I think what we're fighting for in these patients who are surviving their coma from already the intensive care is to offer these patients a life worth living. And that is, again, very hard to quantify, to reduce to one number. What is a life worth living? What is it like to be minimally conscious, to be somehow conscious yet unable to communicate with the outside world? So we can't ask this question to these patients, yet we can in patients who are in a chronic locked-in syndrome. And this is what we did in a paper that came out last year, where we asked patients with chronic locked-in syndrome. So remember, you cannot be more motor handicapped than this. These patients are dependent on others for all activities of daily living, and we asked them how they felt, basically. So maybe we can do it together. You can imagine the worst period in your life, and that is -5. Can you do that? And then the best period in your life, except for this meeting. This is +5. So if you truly have these two markers, you've calibrated your own quality of life scale, and now you can answer my question. For the past 2 weeks, on this scale, -5, +5, you were. If we ask this to locked-in syndrome patients, this is what you get. I think very surprisingly, +3, +4, I don't know how many here had lower numbers, but this, I think, illustrates that we shouldn't judge a book on its cover. This tells us that, yes, you can have a life worth living even in these, from the outside, horrible situation of being unable to move, yet being conscious. Now, the study also identified that some of these patients had a terrible life, and actually some of these wanted active euthanasia. And this was done in France, where this is illegal. So in the study, we also tried to identify variables that explained lower quality of life and tried to influence policymakers and work on those variables and permit these patients to have better access to rehab, speech therapy, and participate in society. So in conclusion, we have seen that the problem of conscious awareness, despite all the philosophical issues, also is a real clinical problem, and that now that we can do these measurements of brain function using different techniques, such as positron emission tomography, looking at glucose uptake, such as resting state fMRI, looking at default mode activity, looking at high-density EEG and combining it with structural connectivity measures, such as here offered by diffusion tensor imaging, we can actually offer these patients a better documented diagnosis, prognosis, and hence a better management. So in conclusion, I hope I've shown you evidence that the neural correlates of conscious awareness can be considered as an emergent property of this collective, widespread frontoparietal connectivity, emphasizing the importance of these top-down connections from this frontoparietal network, global frontoparietal network, with the sensory cortexes being what we would say slave systems. But what is important is the connectivity within this two networks, external awareness, we think, depending on these lateral frontoparietal networks, internal awareness being critically dependent on the functional integration of this midline core. And of course, this then can be used, if true, as a diagnostic marker, and we've seen we need one because we have the problem of misdiagnosis and we sometimes get the label wrong, and we need to be better in predicting good outcome, which is currently being done by multicentric, multimodal imaging studies. We've also seen that better understanding of brain function and possible cognition leads to adaptation of our management, of pain treatment, and also that the identified thalamocortical disconnections can actually lead to new research therapeutic tools, such as offered by currently deep brain stimulation of the thalamus. And I think it's very challenging to see how these clinical entities, which are based on our bedside assessment of motor responsiveness, are now being challenged between by event-related or FMRI revealing subclinical command following, hence challenging this border of awareness, and similarly that EEG-based brain-computer interfaces or real-time FMRI is, in a minority of patients, enabling communication which is not dependent on motor pathways, here challenging this important boundary of functional communication. Basically, we will see in the future that some of these patients will be offered their right for self-determination, because this, of course, gives them the right for autonomy. I would just like to thank all the people who did the job, and thank you for your attention.